everyone. You're probably wondering why I'm here. I have a strong resemblance of someone you all may know. My name is Cruz. I'm here to welcome you to NAMI California's 2020 virtual conference. Mental illness is not a small topic. People live and struggle with it daily. I, in fact, live and struggle with anxiety. I go and see a therapist and I practice self-care. I know that I am not weak when I have anxiety attacks. I am strong. I have a strong voice and I'm standing next to you today to help fight to make California a better place. Just remember that you're not only fighting for you and your family, but you're fighting for me, the next generation. I would like to introduce my mom, the CEO of NAMI California, Jessica Cruz. Thank you.
Thank you, Ella. Thank you for your bravery, your strength, and for being the best daughter. I come from a long line of very strong women, and my mom told me that I needed to be the change that I wanted to see in this world, and that my experiences are my strengths. And all I can hope is that I pass that along down to my own daughter. You see, her sharing her story with you is part of her strength. Just like everyone here, we have a story. As family members, as individuals who are impacted daily by mental illness, we know that our stories, although unique to our own families and ourselves, are very common amongst the group of people that are here today. Thank you all for being here. It's because of you that we're able to continue to raise NAMI's voice throughout this state. Over the last 10 years that I've been with NAMI, we've made significant strides, not only at the Capitol, but locally, where every one of you live. Where there's a NAMI, there's a way. We have all been impacted in one way or another by NAMI, whether it was a family-to-family class, a peer-to-peer class support group, a NAMI on campus club, or you saw a presentation. NAMI has impacted you in your heart in one way or another. And this conference today, our very first virtual conference, is going to cultivate all of your ideas and listen to speakers and learn from each other, interact with each other. Even though we're not together in person, we are still very much connected to one another through our stories. I just want to thank you, from my family to yours, for joining us here today. For many of you, this is your very first conference. And to you, I want to say welcome to the family. For others, you've been here for many, many years, and this is your first time virtually connecting with us. Thank you so much for your continued dedication and support. I'm so excited for the speakers, the workshops, our exhibitors, our sponsors that we have here today to help us make this possible. I am so thankful for each and every one of you for taking time out of your day, the next 2 days, to join us as if we were together. Thank you so much, and welcome to NAMI California's 2020 virtual conference.
Hi, I'm Alex Padilla, California Secretary of State, and I'm proud to be part of this important event alongside NAMI California and each and every one of you. We're convened here today to continue important discussions and dialogue about mental health and to empower ourselves with the information and resources that we need to better meet the needs of our families, of our friends, of our neighbors, and of our coworkers. And it's through these important discussions and conversations that we also work to eliminate the stigma that's too often associated with mental health and too often is a barrier to treatment for people who need it. Now, this year, we've gathered with an awareness, an acute awareness of the impacts of COVID-19 from a health perspective and an economic perspective on so many of our families and our communities. We're also beginning these conversations with a heightened recognition and respect of the traumatic impacts that systemic discrimination and institutionalized racism has had on too many of our friends and our family members. And so I thank each and every one of you for your commitment and for being part of today's efforts, but also for the work that you do throughout the course of the year, advocating for the resources and the policies that we need to better meet the mental health needs and the well-being of all Californians.
Hi, I'm Darrell Steinberg, and I want to welcome all of you to NAMI's annual conference. I know this year is virtual because this has been a year like none other. And amidst all of the challenges and difficulties, there are some silver linings. One of them is that your issue, our issue of making mental health the public health priority that it must be, has been elevated in part because of what people are dealing with during this coronavirus, and it's long past time. Mental health is having its day, and I can't tell you how much I appreciate the NAMI advocates who have stayed with this issue through times when it appeared that nobody really seemed to care. You are heroes and heroines to me, and I'm very proud to work with you. Let's keep going and make sure that we have a system where no one has to suffer needlessly, where families get the support that they deserve, and where we live in a better and healthier world, brain and body. Thank you very much, everyone. Have a great conference.
40 years ago, Harriet Shetler and Beverly Young, our founders, two women who would become the foundation of our NAMI DNA, our mold for miracles, were faced with a kind of wrong thinking that threatened to crush them. They were mothers, each one with a child with schizophrenia, and they had doctors who told them it was their fault. Imagine hearing that from a professional that you respected. Harriet, Beverly, you're parenting wrong. You are the illness. Dare to care. My hunch is that these women felt very vulnerable at that time. Now think about it. No one is 100% sure their own critics aren't at least part right. Still, they clearly had a strength of character, of caring and determination that far exceeded the doctor's opinions. They founded NAMI not in self-pity, but in honor of their children, committed to a healthier arc to their life's journey. I would say the way we've adapted to the changes of this year prove what I believe we are. Unstoppable. Virtually unstoppable. Just look what we've done in this fickle, volatile, unreliable 2020 already. Turning our signature fundraising event, the NAMI Walks, into NAMI Walks Your Way, a vibrant virtual alternative. NAMICon, our annual convention, traded nation in-person networking with something even more intimate and far-reaching. An online NAMICon that saw registrants this year from every state and 38 countries. 25,000 plus registered and nearly 13,000 attending. Wow. Dare to care enough that you don't care what some people think, especially the people who think you don't know enough. Moving forward, NAMI will leverage our experience and expertise to increase our strength as an organization and alliance, as well as the strength of all of the change agents in the mental health world, including you. We will increase our dependence on and belief in diversity, equity, and inclusion. When you leave out people, you leave yourself behind. We will continue to create and convene partnerships, increase our financial strength for everyone in the alliance. Where does this lead us? To get people the best possible care. By 2025, we will have influenced public perceptions of the value of peer-informed mental health education, support, advocacy, and care. And we will underscore the value that got us started at NAMI. Awareness of the range and severity of certain serious mental illnesses, such as schizophrenia, major depression, and bipolar disorder. We will continue to fight for legislation on the federal level with Congress and the administration to get the best possible care, expanding even further telehealth capabilities among many other initiatives. I am very proud of our mental health initiative for frontline health and public safety workers. We are partnering with Starbucks and others on this initiative. A COVID guide has been created in both English and Spanish to answer frequently asked questions regarding the intersection between COVID-19 and people affected by mental illness, their caregivers and loved ones. We're more mobile focused than ever at NAMI as well, and we look to maximize the third screen. We will leverage technology to be more efficient, amplify our advocacy and public awareness efforts, and reach more people through our education and support. We also must double down on getting people diverted from involvement in the justice system. This is especially timely as we are beset as a nation by racial trauma and injustice, systemic obstacles that seem more and more impossible to surmount. The NAMI Board of Directors has issued a resolution on racism addressing this. We must be intentional in our approach. We must not simply condemn racism and call it a day. NAMI, in order to fulfill our mission, must be actively anti-racist. To that end, we must continue to fight to eliminate the mental health disparities perpetrated by racism and racial discrimination. We must continue to spread awareness about the negative psychological, social, educational, and economic effects caused by racism. The disparity in access to mental health care in communities of color cannot be ignored. Neither can the inequality and lack of cultural competency in mental health treatment. We have said this, and I will underscore its importance. NAMI stands in solidarity with everyone impacted across the country. We are in this together, and you are not alone. Let me make another thing clear. The endless circle that sees human beings caught up in the justice system is not just. It's a way of ensuring that this uncaring system continues, almost on its own, with us powerless to stop it. This is fertile soil for mental illness and an invitation to grow the crisis all the time. Dare to care. When there's an emergency, we all know to call 911. What would you call 911 raised to the power of NAMI? We'd call it 988. We're advocating 988 as a 3-digit mental health and suicide crisis line number. And we're also advocating for Medicaid coverage 30 days prior to release from prison. I am particularly gratified with the NAMI Sharing Your Story with Law Enforcement presentation program too. It trains peers and families to share their stories during law enforcement trainings. To paraphrase myself, dare to share. After hearing these stories during their training, officers report experiencing more empathy and understanding for mental illness, and they have an increased desire to adapt their responses to people experiencing a mental health crisis. NAMI's goal is to ensure that every law enforcement officer has the opportunity to participate in this training. We can't stop it alone, but we are not alone. We are working as a vital alliance of 48 NAMI state organizations and more than 600 affiliates. We are working as limited human beings, committed to ignore limits by blazing a trail together. We are working as human beings on behalf of our humanity. In the final analysis, caring is a cause, one that underlies all we do at NAMI. It's invisible, intangible, difficult to measure on a sliding scale, but no one can argue that it's not the most powerful tool we have for changing our world. NAMI is not here to play politics or take sides. The only sides that concern us are the left and right side of our hearts. What do you think keeps that blood pumping? Yes, it's love, friendship, loyalty, compassion, and caring. Let's take an example. When a human being has been laid low by the law or by an accident, when that person is feeling the life drain out onto the street, who does that person call for? That's right. Their mom, their dad, their loved ones. We've all seen it on social media. So many times we either look away or walk away. The person who dares to care never looks away or walks away. They reach out to anyone who reaches out for them. in words or sometimes in a desperate silence. They advocate for change, for the pain to stop. Whether it's get away from my son as a parent inserts themselves between the source of pain and a loved one who is feeling that pain, or an organization that does the same thing. We are all called upon because we care. And we care because we dare to do so. Thank you for everything you do here at NAMI, whether you are a part of the Alliance or a NAMI Walks event, or work tirelessly to tip the scales in favor of mental well-being, or are new to NAMI. Thank you, all of you, for daring to care.
Hi, everyone. I have a special letter to read. Our governor, Gavin Newsom, was not able to record a video for us, so he sent us a nice letter on his behalf, and I'm going to go ahead and I'm going to read it. Dear Jessica, congratulations to NAMI California on another outstanding year of accomplishments and services to those living with mental illness and their families. California has long been a leader in the fight for a better care system for mental health, and I couldn't be prouder to stand alongside of you and your incredible community leaders from across our state to make sure that people living with mental illness and their families are given the same opportunities at a happy, healthy life free from discrimination and stigma. California has moved forward this year in unprecedented ways to meet those very real challenges, and I couldn't have been prouder to have signed so many important bills to advance the need for people living with mental illness and their families. Some of these included critical legislation such as SB 803 by Senator Jim Bell, which supports statewide standards for behavioral health peer support specialists and adds these services as an option to Medi-Cal. SB 855 by Senator Scott Wiener, which strengthens California's mental health parity statute by requiring commercial health plans and insurers to provide full coverage for treatment of all mental health conditions and substance use disorders. And AB 3242 by Assemblymember Jackie Irwin, which establishes streamlined ways to use current technology such as telehealth to make sure individuals in our emergency rooms are able to be evaluated with less delay. I appreciate that NAMI California and its 58 affiliates across the state moved quickly this year to get programs online and available to those in need. These programs have provided a critical stopgap to the ever-growing need for services and community-based supports for those who are isolated and vulnerable during this difficult time. As we continue to move through the past COVID-19 and other challenges we face, this crucial service you provide will be needed more than ever to address the second wave of mental health need we see growing every day. Thank you again, Jessica, and to your incredible group for outstanding advocacy across the state. You work every day to serve your communities and speak truth to power. I stand with you and look forward to a brighter tomorrow together. Sincerely, Gavin Newsom, Governor of California. Good morning, everyone. Welcome. Welcome to NAMI California's virtual conference. I am Jessica Cruz, and I am the CEO of NAMI California. Also, happy Indigenous Peoples Day today. Great day for us to celebrate the land that we live for and live on, and those people who sacrificed for us to be here today. So thank you everyone for being here. We have nearly 1,500 people registered for today and tomorrow's event, where we're going to have a lot of different speakers on various different topics. But my job this morning, and it's an honor, is to introduce our very first keynote speaker, and that's Dr. Tom Insel, who has been a friend and a partner for a long time for NAMI in his work as a neuroscientist. He used to be the director, and from 2002 to 2015 for the National Institute on Mental Health. He has been a strong advocate and continues to do so as his role as the chair of the Steinberg Institute. He's also the founder and the CEO of Mind Strong. Among many other things that he does in his free time, he has just developed a wonderful app to help with people who need support groups and care and connecting with not only peers but others. That was just recently released, and I'm sure that he'll talk a little bit more about that. But Tom has been an incredible and a powerful advocate in making sure that people are first in their recovery and in their voice is heard within any kind of policy. And we are so excited that he's here today to talk about the behavioral health impacts, not only with COVID-19, but also how we can provide solutions and a road to recovery, focusing on people, place, and purpose. Welcome, Tom. Thank you for being here.
Thank you, Jessica. What a pleasure. Real delight to be here. And great set of introductory videos. It's really wonderful to see Dan Gillison in this role as the new director of NAMI, and to see how he's pushing the national organization forward. I think people might want to know that there are probably 20 large advocacy groups that have come together under Dan's leadership to create a kind of unified voice, which we've never had in this movement. And for the first time, there really is a movement. Steinberg Institute is part of that, but there are many, many others, including Mental Health America, the 2 APAs, across the board, really, all demanding a set of new policies, and that will all be public, hopefully within the next week or so. So lots of good things to say about progress at a time when so many people feel the need has never been greater, or as Darrell Steinberg said, it does begin to feel like our day is finally here. I'd like to just, I know there's always a danger of too many slides. Somebody once said that if power corrupts, PowerPoint corrupts absolutely. But I do want to take us through some slides. I'm going to share my screen, and then hopefully we'll have some time for a conversation as well. So if we can just take a moment here, let's see if we can get this up very quickly. Right, here you go. Hopefully you can see this. And I do want to talk about the 3 Ps, which we will go through, as Jessica just mentioned. First, just some recognition again for Indigenous Peoples Day. In any other, not any other, but in many other countries, New Zealand, Australia, parts of Canada today, every public lecture begins on any day of the year with the recognition of those who have been here before and who have done so much to allow us to enjoy this spectacular state. And we don't do this enough. To do it one day a year is probably so insufficient, but it is important to recognize that we live in this historical context, and particularly now when we're dealing with so many of the ravages of climate change, to recognize that for thousands of years, people have figured out a way to live on this land and to live on it together. We're going to talk about 3 things in terms of recovery. I want to spend some time defining the problem, and I know many of you know this much better than I do, so I'm preaching to the converted, but it is important for us to get clear about what things need to be changed. Then talk about the solutions, and finally end up talking a little bit about the 3 Ps, people, place, and purpose, which I think is the essence of recovery. You'll hear more about this from other speakers, including later today, John Sharon, who I will cite as the source of the 3 Ps, because he's one person who's really helped to define that. As Jessica mentioned, I used to work in Washington, and I spent a lot of time as an advisor for Corridor 5 in the Pentagon, for the leadership in the Pentagon. And whenever you'd give a talk to the Joint Chiefs or to anybody at that level, the 4 stars in the Pentagon, they'd always they'd always say, start with the bluff. I always thought, like, bluff, what are we talking about? Well, bluff means bottom line up front, BLUF. And here, the bottom line up front is that we are going to define this problem as a medical problem, but it's so important to remember, particularly in the recovery context, that many of the solutions that we're going to require are going to be social, relational, environmental. There are lots of other things that are not currently part of medical care. And that is the most important message I'm going to have to convey to you, that we have to think outside of healthcare, a little bit the way Dan Gillison was talking about, if we really want to ensure recovery for people. So let's go ahead and begin this journey really quickly on the problem. The governor likes to say that that California is America's coming attraction, and yet when you look at what we're facing, as he is often the one to say, this is the part of the most pressing social issues we're going to have to deal with, even before COVID. Homelessness, the incarceration of people, the breakdown in the healthcare system in so many ways. I love this quote from him that was at the State of the State back in February. Now seems like years ago, but actually was this year. The deeper truth is that our healthcare system has been designed to treat some of our parts, not the sum of our parts. That must change. And I do think, as the letter would suggest that he wrote to Jess, that this is a governor who deeply is committed to this topic, but I must say it feels like everything has gotten in the way. He made a comment at a press conference, about 2-3 weeks ago, with the signing of those bills that he mentioned, that he is still committed, that policies deferred are not policies denied, as he said. We'll get back to this once we can get COVID under control, once we doesn't have to focus on climate change and fires every day. But there is, I think, inside him a real passion for this topic, and a real commitment eventually to put this at center stage. It was amazing in the February 19th State of the State. The only two topics he focused on were homelessness and mental health care. So what is the problem? Well, we've got really a failure of change, that after looking at data over 40 or 50 years, what's so striking is that neuropsychiatric issues have now emerged as the #1 reason for disability or morbidity in the United States, beyond any other medical problem. And as you can see, while we've made such progress on mortality for stroke and heart disease and AIDS and leukemia, especially the cancers of childhood, suicide has gone the wrong way. It's about a 33% increase since the turn of the century, which is just extraordinary, because in most of the developed world, suicide rates have gone down. Mortality has gone down pretty significantly over the last 30 years. The United States, it continues to climb. And of course, part of that, or related to that, is this epidemic of substance use disorder, which is just extraordinary. A tenfold increase in mortality. This graph from the New York Times, you can see that even in 2018, the mortality from drug overdoses had already surpassed car crashes at their peak in 1972, HIV deaths at the peak of that epidemic in 95, and gun deaths at the peak of that epidemic in 2017. So this is a phenomenal source of mortality. A report out over the weekend suggests that in California, we're seeing more overdose deaths already by the end of September than we saw in all of 2019. So continues to be an extraordinary set of issues. If you haven't seen it, Ann Case and Angus Deaton, who got the Nobel Prize in 2015, the Nobel Prize for Economics, have written a book and have been speaking a lot on what they call the deaths of despair. I do think that's a useful construct that they put together suicide, drug overdoses, and alcohol-related deaths as all part of the same challenge for us. In total, even before the pandemic, we were looking at 158,000 of those deaths per year. That number has doubled over the last 20 years. And of course, with COVID, we're expecting it to go up even further. So this deaths of despair concept, I think, is catching on in a number of ways. And as you advocate for change and you focus on this as a medical issue and the mortality associated, I do think it's important to put all of these together because they do travel together and are driven by some of the same factors. COVID, of course, as you heard from those videos earlier, is changing everything. And we're seeing what we think will be the beginning of really a second pandemic around mental health. It has made mental health in some ways a kind of center stage. In other ways, I think there's been such a focus on trying to get control over this pandemic that we are obviously more focused on the vaccine and on interventions for the virus itself. But this is not going away. Threefold increase in depression, increases in suicidal ideation, the economic downturn, as almost all economic downturns, will probably be associated with additional deaths of despair. We don't have great numbers on that. It's hard to predict. But already, as I mentioned, the increase in overdose deaths gives one pause. There has not been an increase in suicide yet, but we know from most economic downturns that that has a 1 or 2 year lag phase. The United Nations has already warned of a second pandemic and has talked about the need for us to get ahead of this in any way that we can. So that really brings me to the description of what is the problem. And I often say we're in a mental health crisis, but it's not like the COVID crisis. This isn't a crisis because of an emerging new disease. It's a crisis in care. It's a crisis where, if anything, we are failing to provide the care that has traditionally been there. People are not recovering in the way that they should, and in some cases would have in earlier eras. Why is that? Well, let me quickly run through what I think are three of the major issues. Most people who could improve and who could benefit are not in care at all. We have a real problem with the quality of care, which I think all of you have experienced. And something we don't talk enough about is, I think, the lack of accountability, the fact that we don't measure outcomes and we don't manage well the things that we don't measure. I just quickly want to unpack each of these before talking about solutions. We'll go through engagement, quality, and accountability very quickly. On the engagement part, clearly we have an issue with not having capacity. The fact that on any given night, there are 356,000 Americans with serious mental illness who are incarcerated and only 170,000 hospitalized tells you, again, this is unique to the United States amongst developed countries, but we have, as Dan Gillison said, somehow managed to criminalize mental illness in a way that our children and grandchildren may never forgive us for. This is something that simply should be seen as unacceptable, and it is fixable. And we have to think through how we're going to do that. There's even a broader problem. When you look at not just those who are incarcerated, but broadly, there are 10 million people with serious mental illness, about 40 some million with any mental disorder. Only about 40% of them are actually in care. Of those who are in care, about 40% would get what we would call minimally acceptable care. That is, care that has any evidence base to it. And most of our treatments, while they're good, only about a third of people will fully recover just from that treatment. Another third will get some benefit, and about a third are going to be, for whatever reason, not able to respond. I call this the 40-40-30 rule, and you can see that we have to move upstream because if you're only dealing with about 5% of people or 6% of people, by the time you look at 30% of 40% of 40%, you're not doing very well, even if the people that you see in the care system are getting a little bit better. This has a lot to do with why we haven't been able to bend the curve and why we're continuing to see those population numbers so poor. Lack of quality, all of you know about this. The problem with fragmentation, a huge issue in California, where we've broken up mental health care into all these buckets. Tremendous delay, particularly for SMI. The care that you get is clearly been built for payers and providers, not for patients, not for families, especially not for families. And it's reactive. It's a crisis system, which really is the most expensive and sometimes the least effective way to deliver care. One other point, I just can't resist mentioning this because it's so important to know, but we have a workforce which is huge in the United States, and it's largely trained in the wrong things or not trained in the right things. This is looking at psychotherapy, psychological treatments, and which ones have an evidence base to them. And you can see that on the right side of this graph, that more than 50% of social workers and about half of psychologists receive no training in any evidence-based treatment that's a psychological treatment. That's just extraordinary because we have treatments that are very effective and that, as in any other medical area, if people use them in the right way, you will expect pretty high levels of response. And yet we have a workforce that has largely not been trained in many of the things that we know really work. And then finally, we have this odd situation where we just don't measure. What we need here are objective, continuous ecological measures. We have almost none of that in this field. And as a result, we're not able to manage well. There's also this weird lack of accountability. Again, something you don't see in the rest of medicine. We're not measuring outcomes. We don't actually have anybody who's accountable for changing those outcomes, which is kind of extraordinary. When I showed that slide about the 30% increase in suicide mortality, an obvious question would be, whose job is that? And there really isn't anybody. There isn't any agency, there isn't any department, there isn't any person who takes that on, who you look to. In fact, most political figures, most mayors, Darrell's an exception, but most mayors in this country or most governors would actually have no idea what the suicide rate is or the fact that it hasn't changed. So we have to make sure that as part of our advocacy, we hold people accountable for knowing that this is a problem and knowing that recovery is possible and that they need to be committed to that. We're still at a point where the money doesn't really align with the things we're trying to fix. So it's a line for medication, it's a line for providing kind of the volume of care, not the value of care. So I really want to focus much more on solutions. I'm going to jump into that because I think that's what gives me hope and every reason why I think we ought to define problems well so we know how to solve them quickly. Basically, these are the three problems that we've just talked about: engagement, quality, accountability. What I'm going to tell you is that we've got solutions for each one. Some of them come from that world of technology that Dan Gillison was talking about. We've got person-centered online care, coordinated care for quality, and we've got ways of measuring that ought to be able to provide the kind of accountability that should be there. You know, technology does make a difference. If you just think about how you buy socks or how you get information or almost anything you do in the realm of goods and services today, it's the Amazon age, it's the Google search age, it's an age in which we get things in a way that works for us, that is on demand, it's transparent, very proactive. That's not the way our healthcare works, and it's certainly not the way our mental health care works. We're in a world that, at least until COVID, was largely brick and mortar. Demand, as I said, or the care is very delayed, and often there's very little information or very little ability to compare treatments and to be an informed consumer here. Just a few kinds of, and just examples of the kinds of things that are possible. Just mentioned that I've just launched this company called Humanest. It really is meant to be a kind of minute clinic married to Peloton, in which people are met where they are at the time where they need help, and are given access to what we call stepped care, which means a whole range of treatments, community groups, one-on-one sessions, all of this available online, with evidence-based practices that are given with a real solution focus. It was an attempt really to build something like Peloton, except in the mental health space. It doesn't solve all problems, but it is, I think, one opportunity to think about if people were to develop online care for themselves, what would they want? What would that look like? How do you focus on what's wrong, what's strong, not what's wrong? How do you empower people with solutions? How do you allow people to not only get help, but give help at the same time? So we're working on what that might look like, and trying to figure out whether engagement will be greater. Part of this is we bring people in from the world of social media, and all of our clinicians are people who also are influencers on social media. Another example of, kind of, I think, a solution on the quality side now, not on the engagement side, is how we engage people with a first episode of psychosis to make sure they'll never have a second episode. So this is coordinated specialty care, or sometimes just abbreviated CSC. The governor put money aside last year so that we could create a new set of programs across California, and now there are very many. I think there are 18 across the state, in which you build out a whole range. We can call it whole person care, to make sure that someone who has a first episode isn't just getting medication and a label, but they're getting access to the range of cognitive and behavior therapies, supported employment, supported education, family engagement, case management, all of that, to make sure that they can recover. We know this works. In New York, where this has been deployed statewide with 25 different sites, you're seeing already population effects on school work and hospitalization rates. Hospital rates are, you can see, they're way, way down to under 10% or around 10% in the first year. Huge increases in global functioning. So we've got now a solution that just needs to be deployed, developed, and integrated across many sites. Finally, one other example of crisis, and I think it's maybe the most, or one other example of quality and its solutions for quality, maybe one of the most important, is changing the way we respond to crisis. Again, Dan Gillison talked about 988, moving from 911 to 988, and we now have a national 988 crisis number. The need here is really extraordinary. This is, I think, one of the ways you break the chain between mental health and incarceration, mental health and criminal justice. When someone's in crisis, there's a very different response. It's a call center hub that gets the call. That's what we can call it, a kind of air traffic control center. Instead of the police or fire, you get a mobile crisis response team in a van with a nurse and a peer and a social worker. Someone goes to the psych ER, not to the medical surgical ER, and there's short-term stabilization. In Phoenix, where this has been done in a population of 4 million people, they've already shown just an extraordinary return on the investment, with reductions in emergency room boarding, reductions in the need for police officers. It's really, we can do this. This is something we just have to understand has to happen as quickly as possible, so we can break that chain with criminal justice. Finally, a little bit on measurement and accountability. There are lots of ways to do this using technology. Several companies have grown up to provide measurement-based care. And as you've already quite aware, I'm sure, we're in this realm of telehealth, but what we do today for telehealth is really, I think, a very early version. Eventually we'll get to a point where the access to people by this third screen, as Dan said, can include access to sensor data and voice and speech, and allowing an emergency room or a mental health care worker or a peer to be able to get a whole set of tools for them that allows them to operate like a master clinician. We're going there, we're not there yet, but that's really where we need to be so that we're able to get that kind of objective, continuous ecological and passive measurement. The question really will be, are we going to be able to align the reimbursement with those kinds of outcomes or not? And that, I think, is the real key. So just, I know I went through this quickly, but I do want you to get the sense that for each of these problems, we do have solutions. Some of them are still evolving, but I'm really quite hopeful that we can make progress on the things that matter. Finally, a word about recovery, and love to hear your own thoughts about this, because I think this is the conversation to have in this next decade, is to build a care system that makes recovery really the focus. And we have to understand what that means. I love the quote from C.S. Lewis that sometimes gets used in talking about recovery, that within every disability, there's a vocation, if we can find it, which can turn necessity to glorious gain. The important thing to remember, and I think something to think about for your advocacy, is that there's a difference between health and healthcare. We tend to think in the policy world that if we could just fix the mental health care system or any other healthcare system, that mortality would come down, disability and morbidity would come down. The WHO and many others are now saying, maybe that assumption isn't quite right. Maybe when you look at the broad world of health outcomes, you realize that clinical care, that healthcare, it's maybe explains only about 10% of outcomes. And there are lots of other things, as it shows here, social and economic factors, health behaviors, many things, physical environment that really matter. It's so important to think about this because we spend in the United States over $3 trillion each year on the healthcare system. And yet on all this other stuff, it's kind of an afterthought. I mean, this is what you have a bake sale for. While we're putting trillions of dollars, 18% of our GDP in the United States, into fixing the healthcare system, which may only account for about 10% of our outcomes. So I think this is the moment to reconsider and rethink this, because for mental health care and mental health outcomes, it's probably even more true. And certainly with the pandemic, we're going to be challenged even more. So this brings me to our 3 Ps: people, place, and purpose. And obviously with social distancing and with people feeling that they're out of work and they've lost their purpose, we're struggling now more than ever. This has got to be, the 3 Ps are not embedded in our healthcare system. These are things that sit outside healthcare, but they're incredibly important for health, and they're absolutely vital for recovery. Vivek Murthy, if you haven't seen this book, it's out recently. He was a previous Surgeon General who I served with in the Obama administration. And he's written a lot about how loneliness is the leading public health crisis today. He talks a lot about the data that shows that a quarter of the population lives alone, half the population is unmarried, and that if we look at not just healthcare, but if we look at health, if we care about health itself, we're going to have to figure out how to create connections. We're going to have to deal with loneliness as a public health issue. It's not something we fix necessarily through the health care system, but it's something that we have to fix if we're going to focus on recovery as a goal. The same with this idea of jobs and education and finding purpose. I love this quote from Nietzsche. He or she who has a why can live with almost any how. It'll be critical as one of the other P's, especially at a time when uh, so many people are being laid off and we've got 8.6% unemployment rate, and it will become even more difficult for those with serious mental illness to find gainful employment. We have got to make this the essence of what we do in terms of our care system. The recovery model overall, and this is really again, the bottom line up front and now the bottom line at the back end, is that it has to go beyond a kind of medical model, right? I do think we have to define the problems as medical because we want parity. We want healthcare to pay for the parts of this that are medical. And if we don't say that these are medical problems, then we don't have really any seat at the table when we argue for parity. On the other hand, we can't assume that that by itself will be enough. And so that is why I make this case for moving to solutions that are social, they're relational, they're focused on purpose, they're focused on lots of other things. It's about family, peers, friends, all of that NAMI has worked so hard to put in center stage. This is going to be what has to become the focus of our recovery agenda in California if we're going to make this work. And I think we've got a governor who cares about it. We certainly have members of the legislature, many of them you'll hear from, who get this, who understand this, and who know how important it is to support clubhouses, family-to-family efforts, that supportive housing, individual placement and training, the kinds of supported employment are just absolutely essential as part of what we're trying to build. So I'll leave you with this kind of a model that what we've had up until now is really not a healthcare system, it's a sick care system. And if we want to build a healthcare system, it's got to be something that's proactive and continuous. It engages people at the earliest stage of their illness, especially those with SMI, that it has this recovery focus, and it takes on not just a treatment approach, but a preemptive or preventive approach, something that we just see so little of in the way that we are now laser-like focused on the sick care system. So sick care is important, recovery is important, prevention is important. We need all of these if we're going to create the system that we want for tomorrow. So I'll finish up with this summary. I hope we have a few minutes for questions. We have a crisis in mental health and a crisis in mental health care. Both of them are important issues. We've got solutions for the big things, for engagement, for quality, for accountability. We actually know how to do this. Technology will help us, and it's getting better all the time to help us even more. For us as a community, we've got to focus on recovery. And this is where peers, this is where equity, this is where the 3 Ps come into place. I love the comment from Dan Gillison, who said that when we leave out people, you leave yourself behind. I think that's a great mantra that we want to think about, particularly in this year when we're having a reckoning, not just with this virus, but also with our systemic racism and our legacy of leaving people out. So people means all people, place means a place for everyone, and purpose is that we give everybody a why so that they can live with any how. Finally, the problems are indeed medical, but we need to think about solutions that are social, relational, and engage the 3 Ps. Thanks so much, and I hope I've left at least 5 minutes, Jess, so we can have some conversation or some questions. Thank you.
Yeah, absolutely. Well, first of all, thank you so much. We are so lucky to have a leader like you who really understands the full scope of what NAMI has been trying to do for the last 40 years. Honestly, it's been a joy and a pleasure to watch as you've been able to lead California to start moving in this direction. So thank you so much for all that you give, not only for the nation, but also now for California. We do have a few minutes for some questions. If you have questions, please go to the Whova app or the desktop. There is a section where you can ask questions. If we don't get to your questions, we will make sure that we at least can get you a response in some way. But I want to start off with just a quick question. What you didn't mention is that you actually traveled throughout the state of California the last year as the governor's advisor on behavioral health. You were able to sit down and visit with counties, peers, families, practitioners. What is it that you learned from families the most in your journey throughout California?
Well, yeah, thanks. It's a great question. I learned a lot, and I would say, special shout out to NAMI families who took me in and often shared not only what they'd been through, but introduced me to their affected family member, so I could learn directly. And there are many people on this call who I really am grateful to. I guess the number one thing that I've discovered is how broken the system really is, that we would never permit the injustice for people with any other serious medical problem. So I can't imagine that a kid with cancer or a kid with bad heart disease or some bad metabolic disease would have to go to jail for that. I can't imagine they'd have to become homeless. I mean, it's just, there are so many ways in which we have failed the people with these disorders and their families. And, Dan in his comments about the birth of NAMI talked about how families were blamed, moms were blamed. We're not out of the woods with the blame and shame thing. We're still in that. And I think we've got a huge, huge amount of work to do. I ended up taking away from, and I spent a year really as kind of the governor's eyes and ears on these issues. And I decided to write a book about it, which I'm in the middle of right now, called Recovery. And what I've just taken you through is actually the outline of the book, because it's really just this argument that the problems are medical, but the solutions have got to be social and relational and all of this much broader lens. And I heard a lot of that. So I'll have a shout out in the book to the NAMI California families who actually educated me about the fact that there are solutions, and that the really egregious sin here is that we don't use what we know, and that we've allowed this to become a criminal justice problem instead of a health problem.
I'm so excited to read that book. I know that I've had the pleasure of you sharing with me a little bit here and there about it. I cannot wait for it to come out. Again, your leadership, your vision around this issue. It's so wonderful to have somebody who kind of gets it, who has the ability to kind of raise the issue to not only medical, but social. And we've been talking about that for the longest time right here. So thank you for that. I do have a question from somebody in our audience. Let's talk a little bit about your Human Nest project. So the question is, would the Peloton type or your Human Nest care work for people who have SMI or serious mental illness?
It's a great question, and I don't know that it's the right solution. I think it would work great for families, and it could become part of a kind of family support system, like the family-to-family system that NAMI already runs. But this can be an ongoing, continuous dialogue, and we create what we call collectives, where people get together and support each other continually, kind of like what Facebook could have been but never became. And that's sort of what we want. But I don't know that for people with SMI, it's the best model. It really was designed more to engage people who are outside of care, so they could get care that has can be delivered by a licensed therapist or by a peer who's been trained up. And we have a bunch of peers that we brought in and trained pretty thoroughly. But I'm willing to, we're just at the beginning. So if I'd love to think about a way that might be possible. Mindstrong, my other project, is entirely SMI. That's what that was meant to do. But that's working in the insurance market and the public markets. This is much more a direct-to-consumer effort.
Would it be a good place for people to start, maybe as they're developing signs and symptoms and they may not know, or even a family member, a good place for them to start too?
You bet, you bet. And one of the things I think we should think about is whether we could create something for families to help them understand what those first stages are like, and give them the support. And again, a lot of this, honestly, you asked the question before about what did I learn from families. They're the experts. Damn it. I mean, it's just incredible how much they have figured out because they've had to. So they're involuntary experts, but they're experts. And so part of what Human-S does is to say, come in and help each other because you figured this out. Maybe not for everybody, but you figured it out for your family. And that can be really helpful to some other families as well.
And that's why NAMI's here, right? We're the expert out of our experiences. And again, it's so lovely to be honored in that way by somebody who has the leadership that you have. So thank you again. I have another question. If you had to choose the most important action we could take today, what would that be?
Yeah, well, it's probably not what you would think, but it's when I look at, because there's so many things that are broken here that you want to fix all of them at once, and you can't. I would start with the crisis problem. I think that, I have 5 grandchildren, and I often spend time when they're jumping around doing something else, thinking to myself, what are they going to look back and say, man, did you screw things up on? And besides climate change, the thing I think that they will never forgive me for is being in this field and incarcerating hundreds of thousands of people with a really bad medical problem that isn't getting treated. That is unforgivable. And I think the way you start that, the way you break that chain is through the crisis now or some approach that allows you to make sure they don't end up in jail. They don't end up, it's not a matter of diversion. You don't even want to get to the diversion stage. You want to build out a system that keeps them completely isolated or insulated from the criminal justice system so that they're in the healthcare system. And we know how to do that. We just haven't done it.
Yeah. And that's a lot of the reason, again, and many people have heard me say it. And we saw my daughter at the very beginning talk about the fight for the next generation. And that's exactly kind of our thought as we're moving through is we fight every day for ourselves and our families, but we also have to fight to make sure that the next generation does not have to have the same fight that we've had, right? Like the idea is that we're making it easier for the next generation, especially when it comes to mental illness and mental health, the care system. It should be easy, accessible. We're doing a great job of being able to talk about it. We see that with young people. It's an easier conversation to have, but now we have to have the system that's in place that's available to people to actually receive the services. Thank you so much for all that you do. Thank you for giving us just a little bit of your time. I always say I could talk to you forever. I'm so fascinated by your work. I wish that I could just, through osmosis, learn everything that you have learned throughout your years. And we appreciate your being an ally of NAMI. We appreciate you raising our voices and all the work you do. Thank you so much, Tom, for being here and being our first virtual keynote speaker for our conference.